high quality evidence is available for hormonal therapy. There's the adrenocortical corticotrophic hormone ACTH and oral steroids and vigabatrin and combination of hormone therapy with this vigabatrin in the treatment for West syndrome. United Kingdom infantile spasm study compared hormonal treatment with vigabatrin for epilepsy and the developmental outcome at a short term, there is a 14-month and 4 year of age. It was observed that hormonal therapy was superior in terms of initial cessation of epileptic spasm or infantile spasm, but not at a 14-month and 4 year of age. However, successful initial control of epileptic spasm was associated with better long-term developmental outcome. Concession statement for first-line treatment of West syndrome. First-line treatment of West syndrome, there is a hormonal therapy, adrenocorticotrophic hormone ACTH, and oral steroids and vigabatrin. Hormonal therapy should be preferred for a case other than tuberous sclerosis complex. Regarding the combination treatment, in view of limited literature, the group suggested the need for more data before recommending, as it is a routine first-line treatment. So first-line treatment is a hormone therapy and oral steroids. Hormonal therapy. Hormonal therapy in form of ACTH and oral steroid has been widely used. ACTH has a disadvantage. They are parenteral and maybe high. There's a parental route and cost is also high. And oral steroids have an advantage of ease of administration due to oral route and low cost. Dosage schedule for ACTH. Typically, in a high dose of the ACTH, there is a 150 international units per meter square. There is a body surface area has been used, and a low dose schedule, there is a 20 to 30 international units per day has been used. There is a need of high quality study and evidence to conclude the optimum dosing protocol of ACTH. Dosing schedule for prednisolone. In previously mentioned in UK, infantile spasm study, 40 to 60 milligram per day of oral prednisolone was used. However, this dose may be too high for our smaller size infant in India. Consensus statement for hormonal therapy in West syndrome. Both ACTH and high-dose prednisolone has reasonably similar efficacy and less side effect profile for treatment of West syndrome. Initial choice depend on the preference of treating pediatrician, certain factor. There is a cost, availability of infrastructure, and personnel for a daily IM injection. High dose of ACTH therapy may be considered in cases who fail to respond with oral steroids. High dose of ACTH is preferred therapeutic option as compared to low dose of ACTH. Suggested dose of ACTH 150 international units per meter square body surface area or 6 units per kg IM once daily for 2 weeks to assess therapeutic response. High dose of prednisolone, there is a 4 milligram per kg per day, is recommended in a view of better efficacy and similar tolerability to usual dose. There is a 2 milligram per kg per day, and this treatment should be given for 2 weeks to assess response. If there is a clinical spasm suggestion, EEG should be performed to look for resolution of Hips arrhythmia if there is an easy resolution as well as that is electroclinical suggestion, then first-line drug ACTH or prednisolone should be tapered off over 2 to 4 weeks. In case of there is a no clinical spasm suggestion or persistence of hips arrhythmia on EG, then first-line drug should be tapered off and second-line treatment should be started. If the EG is normal or shows background abnormality such as slowing but no epileptic form abnormality, then the hormonal therapy can be tapered off and there is no need to start any other anti-epileptic drug treatment. If the EEG shows epileptic form of abnormalities such as multifocal or focal spasm discharge, the patient may be started on an anti-epileptic drug such as topiramate, sodium valproate, or zonisamide for a period of 12 to 24 months. And there is a evidence to prefer any one of these anti-epileptic drugs. Treatment of relapse in case of West syndrome. The treatment of children who have initially responded with hormonal therapy should be individualized. An option include repeat trial of hormonal therapy or vigabatry in case of relapse. Consensus treatment. There's a pre-hormonal therapy investigation, monitoring, and precaution on a hormonal therapy. Screening with X-ray chest and Mantoux test is recommended in children at a high risk, the family history of contact or a suspected immunodeficiency. Children with West syndrome on a hormonal therapy should be monitored for an adverse effect, and parents should be counseled regarding the adverse effect. Clinical surveillance or infection in when there is a child on a hormonal therapy. At least weekly blood pressure monitoring need to be done while child is on a therapy in West syndrome. No live vaccine, there is a oral or oral polio or measles should be given while child is on hormonal treatment, and for 1 month after stopping the therapy, you should give this live vaccine. Children on a systemic corticosteroid for more than 2 consecutive or 3 cumulative weeks within last 6 months are at a risk of adrenal insufficiency, and hence, in case of intercurrent illness, oral intolerance, or surgical procedure, hydrocortisone should be administered in a stressed dose that is 25 to 100 milligram per meter square in a divided dose. Consensus statement for vigabatrin in West syndrome. Vigabatrin is a first-line treatment among the infantile spasm with tuberous sclerosis complex. Among the patients with infantile spasm, there is a non-tuberous sclerosis. Vigabatrin should be considered for a treatment when the hormonal therapy and steroid are either contraindicated or failed. Vigabatrin is a started dose. There is a 50 milligram per kg, high 50 milligram per kg every 3 to 7 days interval as a tolerated maximum dose 150 milligram per kg, maximum within 14 days, or a suggestion of clinical or electrophysiological spasm has been achieved, whichever is earlier. If effective, the duration of therapy should be generally limited to 6 months. Parents should be explained the risk of possible visual side effect with vigabatrin and its minimal risk in infant and among those with a less than 6-month drug therapy. Baseline and 6-monthly ophthalmological evaluation, including fundus examination recommended for children on vigabatrin with West syndrome. Electroretinography ERG optimal at 6 monthly interval in case of prolonged vigabatrin therapy in children with West syndrome. Consensus statement treatment after failure of hormonal therapy and vigabatrin. Among the children who failed to hormonal therapy and vigabatrin, use of benzodiazepine, sodium valproate, topiramate, and zonisamide may be considered as an anti-epileptic. Trial of pyridoxine, pyridoxal phosphate, folinic acid, and biotin may be considered for minimum duration of 7 days among those with epileptic spasm of unknown etiology and fail to respond to the first line agents. There is a hormone ACTH or prednisolone therapy. Consensus statement for the dietary therapy for West syndrome. Dietary therapy should be considered with West syndrome after the failure of hormonal therapy or vigabatrin and one more anti-epileptic drug provided center providing this is accessible at this center. Ketogenic diet is preferable, but in a low resource setting, the modified Atkins diet may be used in case of West syndrome. Consideration while starting the diet include family education, motivation, and availability of trained dietitian for ketogenic diet. For infant less than 18 months of the age, inpatient initiation is recommended. It contains low fat and protein ratio should be used. And fine tuning of diet is needed to maintain growth of the child. Dietary therapy should be tried at least for 3 months before considering it is ineffective. If effective in controlling spasm, it should be continued at least for 2 years. Epilepsy surgery. Consensus statement for epilepsy surgery in West syndrome. Children should be evaluated for epilepsy surgery after the failure of first-line treatment. There is a hormonal therapy and vigabatrin. If there is a presence of surgically resectable lesion, that is cortical dysplasia, hemimegaencephaly, Sturge syndrome, tuberous sclerosis, and if there is a presence of focal features on a clinical semiology of spasm on EEG. Consensus treatment for early diagnosis. Health professional dealing with follow-up and early intervention of high-risk infant should be trained to ask about the recognized epileptic spasm. Parents of high-risk infants should be made aware about risk of epileptic spasm and educated to recognize spasm and report to the health facility early in case of spasm occur for early diagnosis. In every infant with developmental delay, presence of epileptic spasm be inquired for especially at a 10-week and 14-week during immunization visits. If spasm are suspected, EEG should be urgently obtained within 24 to 48 hours. Infant diagnosed with tuberous sclerosis complex antenatally or at birth should be referred to the pediatric neurologist for consideration of surveillance of EEG monthly for 2 months of age and pre-symptomatic treatment with vigabatrin. Supportive care in case of West syndrome. Anticipatory evaluation and appropriate management of comorbidity, especially related to the feeding, oralizing, neurodevelopmental delay, constipation, sleep, and cognitive ability should be ensured in case of West syndrome during supportive care.